Hello, everyone. This lecture will be recorded on the concepts of care for patients with cancer. And the first few slides talks about the uh, pathophysiology and the epidemiology and the prevalence of cancer, the incidence and the pathophysiology of cancer. So here's the first slide, talks about the prevalence and incidence. And although the cancer is often considered as a disease of aging, with the majority of the cases diagnosed in those over age of 55 years, the cancer occurs in people of all ages. So it affects people of all different ages or age groups. The reason why sometimes scientists and people, they refer to the cancer as the disease of aging is just because from the pathophysiological perspective, um, recall we talk about the genetic hits, which means that, on a constantly on a daily basis, our immune system, when it's competent, able to detect and identify and find out the mutations and able to fix them. So once the immune system is able to detect any mutations and fix it, then that will be called genetic hit. So so the longer we live, the more frequent, genetic hits we will experience. So that kind of add another factor, which is the aging. The longer you live, the highest the risk would be to develop cancer because of, or due to this kind of, concept or this scientific explanation, which is the genetic hit experience over time. So an estimated of more than 1.5 million people in the United States are diagnosed annually with invasive carcinoma, and that exclude the basal and squamous cell skin cancers. Um, the in terms of the prevention and preventive efforts, the incidences of many types of cancers have been declined or have declined largely as a result of preventive measures and efforts. So however, the incidence of other types of cancers such as kidney, thyroid, liver, uterus, skin melanoma, multiple myeloma, and non-Hodgkin's lymphoma, these types of cancers has been increasing. In general, we can see that the incidences of many cancers have declined largely as a result of the preventive measures and efforts. The incidence of cancer in men or males versus females, there are some differences as we compare the cancer incidence and prevalence in males versus females. The Annually, first of all, there's about almost 600,000 Americans are expected to die from the cancer or as a result of cancer. So cancer-related deaths will exceed a 600, around roughly estimated number, slightly less than that number, which is 600,000. The cancer-related deaths annually in the United States, which makes about more than 1,600 people may die from cancer on a daily basis. There is a significant progress that has been made in controlling cancers for long periods. Some of the differences between or among males versus females, we can look at the cancer incidence by site and gender and see some of these differences or identify some of these differences. For example, males, the majority of the cancers among males will be the highest percentage of cancer incidence would be what is called the prostate cancer, which accounts for about 19% of all cancers that affects males. Second, type of cancer or cancer would affect males. Second to the next to the prostate cancer, which is 19%. Lung cancer, which accounts for 14% of all different types of cancers that affect males. Next to that would be colorectal cancer, colon, rectum, or CRC, colorectal cancer, accounts for about 9% of all different cancers that affect males. And then we have other types like urinary bladder, which is about 7%, and other types. On the other hand, for females, the highest percentage of cancer would be breast cancer, which accounts for 30% for females. Second to that, or next to the breast cancer, which is 30%, lung cancer accounts for 13% in females. And third would be colorectal cancer, colon rectum cancer, 7%, uterus about 7%, and then thyroid 5%, and then other types. So I'm just indicating or listing here the highest percentage of cancer in males versus females. On the other hand, look at the cancer deaths by site and gender. You will find in males the highest percentage of deaths would be in males due to the lung and bronchus cancer. 26% of deaths in all different types of cancers in males would be due to the lung and bronchus cancer. Second to that, 9% of all deaths would be due to prostate cancer, and then 8% would be due to the colorectal cancer. Pancreas about 7%, which is pretty much the same with females. 7% pancreas, also due to the pancreas is 7%. On the other hand, for females, even though the incidence of the cancer in females of the lung and bronchus type, it's lower incidence than males, but it's number one. So it's not due to the breast cancer. The highest percentage of deaths in females is of the lung and bronchus cancer. So it's about 25% of females, or females with cancer, with different types of cancers, die from the lung and bronchus. So lung and bronchus cancer accounts for 25% of all deaths or cancer deaths in females. And then second to that, or next to this, would be the breast cancer, which accounts for about 14% of all different cancers or different types of cancers in females. So even though the breast cancer in females accounts for 30% in terms of incidence, but when it comes to the cancer deaths by site and gender in females, the highest is due to lung and bronchus cancer, 25%. So stats talking or statistics, the stats or statistics are helpful in describing the scope of cancer as a public health problem, but they cannot describe the combined physiologic, psychologic, and social impact of cancer on individual patients, their caregivers, or families, because the care of patient with cancer would involve the allocation of resources, not just for the individual patient, but also for the caregivers, for the family. So despite the advances in treatment and care, there continues to be a great deal of anxiety and fear associated with diagnoses of cancer. Still, the anxiety is high, is augmented and high to a large extent, as we associate it, or as we correlate it with the culture. Some culture, they don't even call the cancer by its name, cancer. They call just say that disease. Given the frightening kind of aspect, or how much they are afraid of even talking, mentioning the cancer as a disease, because it's as we said, the anxiety and fear that is associated with diagnosis of cancer, it's still high, and it continues to be a great deal. And it's again, it's what is called the cultural specific, culture specific. Some cultures, they have higher anxiety levels and fear than others. Um, so we have a case study, which is Ellen is an 18-year-old friend of yours. She's trying to get into the nursing school program, or comes to you and puts spot on her back. Um, she is very worried because her mother died of cancer. So there's a history of cancer in the family, and wants to know, she's seeking information and knowledge to know more about cancer. So we can say that the cancer is a group of diseases characterized by uncontrolled and unregulated growth of cells. The cell multiply, divide with no control. There is no not abiding or in compliance with any type of control or any rules. And cancer affects people of all ages, affect men more than women. And we can say it's the second most common cause of death in the United States after heart disease. So heart disease comes before the cancer in terms of the most common cause of death. So cardiac, and then next to that would be cancer. But more people are surviving from cancer. So we have a lot of cancer survivals nowadays. And even some, one day I was doing, research in chronic diseases, and few patients have, approached me and saying this was like 10, 15, 10 years ago. And they just, some patients just approached me saying that I would like to be called a cancer survival, not cancer patient. I'm no longer having cancer now, but I experienced cancer, and I fought it, and I completely, recovered from cancer. So I'm cancer survival. I would like to be called that name, not cancer patient. Even I completely recovered and healed from cancer. Um, some of the types of cancer that are on the rise, like cancers, like skin cancer is one of them. Skin cancer is like one form of cancers that it's on the rise. It's increasing in terms of incidence and prevalence. The pathophysiology, just briefly going over the pathophysiology of cancer, you will find that there are two major dysfunctions in the process of cancer development. One defect related to the cell proliferation, which is the growth of the cell and cell division and growth, which is proliferation, and another defect which is related to the differentiation of the cells. So the cell grows and divide and grow and divide with no control. So it's uncontrolled, unregulated growth or cell division. And the new cells, the cancer cells, they are undifferentiated. In other words, that these cells, they no longer can perform the function which was supposed to be to be assumed by these cells. So we have a lot of discussion here on these slides, talk about these two concepts, which is the defective cell proliferation and the defective cell differentiation. So normally, most tissues contain a population of undifferentiated cells known as stem cells. And then when they become differentiated, they will assume and will have a specific role and function. For example, there are cells that are function to secrete, so they are secretory cells. Cells that are responsible for contraction, cells responsible for the absorption, or cells for this. So there are specific function for each cell, which is what is called the differentiated cell. Undifferentiated doesn't have any function, or it used to have a function, and then with the changes from a normal to abnormal or to become cancer cell, then it has no function, which is undifferentiated. The one of the features or the rules of that govern the growth of the cells is called the um, growth by inhibition, which is that the cells are not they are inhibited to grow on the top of each other. So but in cancer cells, they will grow on the top of each other, then they will create what is called the pyramid effect. They will divide continuously, indiscriminately, continuous cell division, and they do not abide or compliant, because, they're not compliant with what is called the contact inhibition. So the contact inhibition prevent the normal cells to divide on the top of each other. Cancer cells, they don't belong, they don't comply with this rule. At least this is an example of the rules that, the cancer cells that are not compliant with contact inhibition. So that's why they will grow on the top of each other and create what is called a pyramid effect, which is, in other words, we call it a tumor. And like one centimeter tumor contains about 1 billion cells. Just that small of a tumor, 1 centimeter tumor, in terms of size, that includes about 1 billion cells. So under normal conditions, the differentiated cells is able to first, it has a specific function, and it's stable, and it has specific function. And once it's stable, it will not de-differentiate. In other words, that revert to a previous undifferentiated state. So that's under normal conditions. But that's not the case with the cancer cells. They are able to de-differentiate and they become undifferentiated cells with no function. In terms of the defect in cell differentiation, we have the specific genes called proto-oncogenes. These cells, these oncogenes, we'll explain in the next slide about the oncogenes. These oncogenes, they are proto-oncogenes. They are genetic locks that keep cells functioning normally. In other words, that when this lock is unlocked, as may occur through the exposure to carcinogens or oncogenic viruses. So during the exposure to the carcinogens or oncogenic viruses, this lock will be unlocked. And then the genetic alterations and changes and mutations would occur. So when the proto-oncogene are mutated, they can begin to function as oncogenes. So proto-oncogenes are protective, they are like genetic locks, but when they become, once mutation occurs, then these proto-oncogenes begin to function as oncogenes, which is, in other words, the oncogenes, we don't want the oncogenes because they are the tumor-inducing genes. So the oncogenes can change a normal cell to a malignant one. Tumor suppressor genes, they are the genes that would suppress the tumor or suppress the cancer from being developed. So tumor suppressor genes, it suppress the cancer development. So because you are already nursing students, the LM asked you to explain the biology of cancer to her. What do you tell her? So this is more pathophysiology question about the cancer. So the cell proliferation or cell growth originates in the stem cells and begins when the stem cell enters the cell cycle. Normally, cells differentiate and become mature, functioning cells of a certain kind of tissue. Each cell has its own function, specific function, and there is an equilibrium balance between, which is the homeostasis in this case. So there is an equilibrium between cell proliferation and cell degeneration. In cancer, the cells respond differently than normal cells to the intracellular signals that regulate the state of dynamic equilibrium. So the cells respond differently and divide indiscriminately and haphazardly. So just haphazard responses, and in terms of cell division and cell differentiation from the cancer cells. So when they produce more than 2 cells at the time of mitosis, there is continuous growth of tumor mass called pyramid effect, which is the resultant large number of cells built up on each other, built on the top of each other, which is, in other words, we call it tumor. The cell differentiation, which is normally a stable, orderly process that progresses from a state of immaturity to a state of maturity, so which is the process that makes the cell from being immature cell to become mature cell, able to function. The cancer results in a malfunction in that process. So the cancer involves the malfunction of genes that control differentiation and proliferation, both phases or both processes. And second slide talks about the 3 phases of the cancer development, which is the initiation, promotion, and progression. Initiation, promotion, and progression. The gene mutations, there is an inheritance, about 5 to 10% of all cancers that are known or believed to be, a predisposition, genetically predisposition to cancer, and so they are inherited. So there is an inheritance which accounts for about 5 to 10%, what is called genetic predisposition to cancer. But most cancers do not result from the inherited genes, but are acquired from damage to genes occurring during one's lifetime. So the majority of cancers do not result from the inherited genes, but are acquired from the damage to the genes during, which would occur during one's lifetime. So that acquired mutation is passed on to the cells, to all cells that develop from the single cell. The damaged cell may die or repair itself. So, however, if the cell death or repair doesn't occur before the cell division, so the cell unable to recover, unable to doesn't make it, so death or repair doesn't occur before that cell division, then the cell will replicate into a daughter cells, each with the same genetic alteration, which is an altered genetic makeup. So Ellen tells you, I knew I would get cancer someday since my mother died from it. What can I tell her about the genetic link in the initiation phase? So we said we have the initiation phase, promotion, and progression phase. So in the initiation phase of cancer development, a common misbelief is that the development of cancer is rapid, haphazard event. However, the cancer is usually an orderly process. It's systematic, it's orderly process comprising or consists of several stages and occurring over a period of time. Sometimes it takes we'll talk about, how long it would take for the promotion, sometimes from 10 to 40 years to develop in the cancer. So the first stage, which is the initiation, it's the mutation in the cell's genetic structure. So there is a mutation in the genetic makeup or the genetic structure. That's in the first stage, which is the initiation. The genetic mutations can occur in two different ways. Mutations to the genes can occur in two different ways. Either it's inherited from the parent, passed from one generation to the next generation, or acquired during a person's lifetime. And we mentioned earlier about that 55 up to about 5 to 10% of all cancers or the predisposition to the cancers are inherited from one's parents. So the inheritance or predisposition genetically account for only 5 to 10% of all cases of cancer. So these genetic alterations lead to a very high risk of developing a specific type of cancer. But however, that most types of cancers do not result from the inheritance or from the inherited genes, but are acquired from damage to the genes, as we said previously. Carcinogens. And we talk extensively about carcinogens in pathophysiology class. And carcinogens can be of a chemical type, radiation, or viral. So carcinogens, which are the cancer-causing agents, any agent that can, may lead to or put the patient at risk to develop cancer is called carcinogen. Now, the chemicals were identified as cancer-causing agents. And we have lots of types of, these chemicals nowadays, and even in the past, we used to hear a lot about the monosodium glutamate, MSG, one of them. The chemical that we use in sweetener, the sweeteners, called aspartame, which is one of the major ingredients, and diet, Coke or diet, Pepsi, or it's part of the major ingredients of some of the sweeteners called aspartame, and it's believed and identified as one of the carcinogens. So the people or persons who are exposed to certain chemicals over a period of time have great incidence of certain diseases than others. So it's mostly about the length of exposure to that specific chemical or that carcinogen. Radiation. Certain malignancies have been correlated with radiation as a carcinogenic agent. Radiation historically identified and known to be a carcinogenic agent, and that's why we always protect ourselves from the radiation with the lead apron, or eliminate the exposure to radiation as much as we can. So certain malignancies have been correlated with radiation as a carcinogenic agent. We can list of them like leukemias, lymphoma, thyroid cancer, and other cancers increased in incidence in the general population of like for example, some incidences in Japan and the in Russia, and you'll find, from these, like the atomic bomb explosions and nuclear explosions, people over, for years and decades after these incidences, they will suffer from the effect of the exposure to radiation. Skin cancer is the most common type of cancer among whites in the United States. One of great concerns also is the incidence of the increased incidence of melanoma. And we know that melanoma, skin cancer, it's, although the cause of the melanoma is probably multifactorial, the UV radiation, ultraviolet radiation secondary to sunlight exposure is linked to the development of melanoma. Viral carcinogens. So previously we said that the oncogenes are the tumor-inducing genes. So certain DNA and RNA viruses, termed oncogenic, can transform the cells they infect. When these viruses infect the cells, they're able to induce malignant transformation. So viruses have been identified as causative agents of cancer in animals and humans. And all these listed in this slide, these are some types of of the viruses that are linked and associated and correlated with with the development of certain types of cancer. Burkitt's lymphoma. Burkitt's lymphoma is associated with the EBV, which is Epstein-Barr virus. An example of that. We also sometimes we discuss the phases of HIV/AIDS or HIV positive patients when they progress to, or develop the being diagnosed with AIDS. So persons with the acquired immunity deficiency syndrome, which is AIDS, which is caused by HIV virus, they also have a high incidence of Kaposi sarcoma, for example, and Kaposi sarcoma, which is one of the skin infections, or infections, and that's usually one of the criteria to diagnose patients with AIDS, who has been like HIV positive, and once they develop Kaposi sarcoma, then they will be identified or classified as they are now with AIDS, because to classify patients with AIDS, HIV positive patients with AIDS, there are specific criteria, and Kaposi sarcoma one of them. Hepatitis B virus. Other viruses that have been linked to the development of cancer include hepatitis B, which is associated with the hepatic carcinoma, which is the hepatocellular carcinoma, liver cancer. So the ultraviolet radiation is considered a carcinogen. And we mentioned earlier, we said that the carcinogens may be a chemical, radiation, or viral. So the ultraviolet UV radiation has long been associated with melanoma and squamous and basal cell carcinoma, and which affects the skin. The skin cancer is the most common type of cancer among whites in the United States, and I mentioned that earlier too. So this is one of the great concerns, which is the increase in the incidence of melanoma. And although the cause of the melanoma is probably multifactorial, the ultraviolet light or radiation secondary to the sunlight exposure is linked to the development of that melanoma. Promotion, which is characterized by reversible proliferation of altered cells. An important distinction between initiation and promotion is that the activity of promoters is reversible. And that's the key concept in cancer prevention, that the activity of promoters is reversible. And approximately about 1/3 of cancer-related deaths in the United States are related to tobacco use. And here we would identify what is called the complete carcinogen. And cigarette smoke has been proven, has been identified as tobacco as an example of the complete carcinogen, which means that this complete carcinogen is capable of the initiating and promoting cancer. So it's responsible for the first two steps and phases of cancer development, the initiation as well as promotion. So it's complete carcinogen, tobacco. Late period or latent period as one of like category or period under the promotion phase, which may range from 1 up to 40 years. So it could take up to 40 years after being exposed or in the exposure, constant exposure to certain chemical or virus or, carcinogen, that when the signs and symptoms or when the clinical appearance and the clinical manifestations would occur or be present. So the tumor that is about 1 centimeter, which is 0.4 inch in size, it can be palpated, so it's palpable, so it can be detected by palpation. And you'll find that this small 1 centimeter tumor, it will include about 1 billion cancer cells. 1 billion cancer cells. And in terms of the diagnostic testing and able to detect that by MRI or by CT, the 0.5 centimeter size tumor, it can be detected and by the MRI, by the magnetic resonance imaging machine. The progression, which is characterized by the increased growth, invasiveness, metastasis. So progression is the final stage in the natural history of cancer. So the last stage of cancer development would be progression. And metastasis is the spread of the cancer to the distant site. It can metastasize also to the adjacent cells by what is called the process is called local seeding. And then to the metastasizing to the distal organs and sites, either via the lymphatic or blood. Certain cancers seem to have an affinity for a particular tissue or organ as a site of metastasis, like breast cancer metastasized to bone, liver, brain. So there is a high affinity for certain cancer cells to metastasize to certain organs and sites. Colon cancer often will spread to the liver. Hepatic cancer, colon cancer result in. So the primary cancer is colon cancer, and then once it metastasizes to the liver, and the secondary cancer is the liver cancer. These are some of the main sites of metastasis. And this is the pathogenesis, explain the pathogenesis of cancer metastasis. So to produce metastasis, tumor cells must detach from the primary tumor and enter the circulation, survive in the circulation to arrest in the capillary bed, adhere to the capillary basement membrane, gain an entrance, and then it will gain entrance into the organ parenchyma, which is the tissue or cells of the organ. respond to growth factors, proliferate, which is an increase in cells number, and division, cell division, and will induce angiogenesis, which means create its own blood vessels, and with the VEGF, growth factor will be produced, so it will increase the build up its own blood vessels called angiogenesis. So it has its own blood supply, so it can survive, and it will evade the host defenses. In other words, that it will create its own antibodies to hide or to hide its own receptors, so it will evade the immune system. And that's how the cancer cells are able to evade the immune system. Otherwise, T lymphocytes or B lymphocytes or immune system cells or lymphocytes can destroy the cancer cells. But these cancer cells can produce their own blood vessels, first of all, angiogenesis. Second, they also can produce the antibodies to hide and to cover their own receptors so they won't be detected by the immune system and the lymphocyte, the T lymphocytes. So it will evade and get away with that surveillance system. So it will proliferate, divide, and evade the host defenses. So once free from the primary tumor, so the cells detached from the primary tumor, metastasis or metastatic tumor cells frequently travel to distant organs. So distant organ sites via either the hematogenous, which is via the bloodstream, via blood, through the blood, or through the lymphatic fluid, fluid and lymphatic glands. These are the two main routes of metastasis. They are interconnected, given the pathogens. I mean, the anatomy of the lymphatic fluid and how the blood vessels are interconnected. So we can always see that all theories will indicate that the tumor cells metastasize via these two methods, which is the hematogenous and lymphatic routes, which is the lymph and the blood. And this slide talks about explains the concept of how the cancer cells are able to evade the immune system, and by creating their own antibodies, which is the tumor associated. It's the tumor associated antigens are covered by these antibodies. So the antibodies will cover these TAAs, the antigens. So that's because under most circumstances, immune surveillance will prevent these transformed cells from developing into clinically detectable tumors. But once these tumors or cells are able to hide and cover their own antigens, TAAs, with antibodies, the antibodies that they produce, then they will evade that surveillance and immune system. Another aspect or component of the role of the immune system in the development of cancer is cytotoxic cells. The cytotoxic cells are supposed to kill tumor cells directly. So cytotoxic cells, they play a dominant role in resisting tumor growth. Tumor growth is supposed to be halted and stopped by the action of these cytotoxic T cells. And another type of the immune system cells is called the natural killer cells, NK cells. They are also able to directly lyse or dissolve the tumor cells spontaneously without any prior sensitization. Because the other types of like T cells and B cells, they need supposed to have memory cells that are available prior to, right, to be able to identify the target, or target cells to be destroyed. The natural killer cells are able to, the NK cells are able to directly lyse and dissolve tumor cells spontaneously without any prior sensitization. And these NK cells, they are usually stimulated by the interferon type 2, IL-2, which is released from the T cells, and that would result in the increased cytotoxic activity, which is destruction of the cells. So next slide talks about the oncofetal antigens. So these antigens are found on tumor cell surfaces, inside tumor cells, and fetal cells. And these oncofetal antigens can also be used used as tumor markers. So they are used as tumor markers. These tumor markers are clinically useful to monitor the effect of therapy and indicate a tumor recurrence. So it will be very helpful to also, we'll talk about diagnosis as well. It will help in the health promotion, like preventive measures. For example, when the EFP high or elevated, then that indicates a certain type of cancer, like hepatic cancer. When the PSA is elevated, prostate-specific antigen is elevated, that's an indication. Also can give us an alert that the patient is experiencing also prostate cancer or an early development of prostate cancer. So these are the fetal, the tumor markers are called oncofetal antigens. So it will help in terms of they are clinically useful to monitor the effect of the therapy for the patient on specific medication or therapeutic management, a protocol, and you can test or evaluate the effectiveness of that therapeutic regimen based on the level of these markers. And also it can help us as it provides an indication about the tumor recurrence. However, the oncofetal antigens, they are not 100% specific for tumor recurrence, because the tumor markers, they are affected by various factors that need to be accounted for when reviewing these results. There are other factors that like confounding factors that are going to affect the tumor markers level, which not necessarily has to be linked directly to the cancer itself. Like a CEA. An example of that would be like, the persistence of elevated pre-op CEA titers after surgery. It may indicate that the tumor was not completely removed. A rise in that CEA levels after chemotherapy or radiation therapy, it may indicate recurrence or spread of the cancer, or may be affected by chronic lung or liver disease and smoking. So these oncofetal antigens, they are not 100% specific for tumor recurrence, but they are clinically useful to monitor the effect of, or the effects of therapy and indicate any tumor recurrences. These are some of the examples of the oncofetal antigens, which is the cancer or tumor markers, and each one would be used for specific, clinically for specific types of cancer next to it in parentheses. So Elam asks you how they will tell if her cancer is bad or not. What can you tell her about how and why cancers are classified? Now, the tumors can be classified as benign or malignant. And in general, when we say that benign neoplasm are well differentiated, and malignant neoplasms or cancers or tumors range from well differentiated to undifferentiated. The ability of the malignant tumor cells to invade and metastasize, metastasis, is the major difference between benign and malignant neoplasms. Benign doesn't metastasize, encapsulated in a capsule, will defined capsule in place, doesn't invade adjacent or distant organs or cells. Malignant tumor or tumors, malignant cells able to do that and infiltrate, invade adjacent and distant cells in a way in a method called metastasis. Also, tumors can be classified according to the anatomic site, histology, like grading, like grade 1, 2, 3, 4, A and B, and the extent of the disease, which is the staging. So classification of the tumors can be either we can classify it according to the anatomy, the site, anatomic site, histology, which is the grading, grades, and extent of the disease, which is the staging, which stage. The tumor classification system provide a standardized way. So all professionals across the globe, they will have, once they look at the report, they will, when we say stage 1, we would all know that stage 1 implies 1, 2, 3, 4. So the tumor classification systems provide a standardized way to communicate the status of the cancer to all members of the interprofessional care team. It assists in determining the most effective treatment plan as we develop the care plan for the patient that will help and assist us in determining the most effective treatment plan. Also, it will evaluate the treatment plan as we do we implement and then we have to evaluate. So first of all, it's standardized, provide us with a standardized way to communicate the status of the cancer among all interprofessional healthcare team. Second, it will assist in determining the most effective treatment plan. And third, it will also assist in the evaluation of the treatment plan and prediction of the prognoses, and help also. The last one would be to compare like groups for statistical purposes, which is more of research endeavors and research, scholarship and research studies. So classification of cancer, benign versus malignant neoplasm. And we said we classify the tumors as benign versus malignant. In general, we can say that the benign neoplasms are well differentiated, and the malignant neoplasms range from well differentiated to undifferentiated. Malignant tumors that are in capsules, they are well, encapsulated like in a well-defined capsule. Malignant cells, they don't have, like conformity or don't belong to a specific, conformity or shape. Classification systems, we talk about the benefits of using these these classification systems as a standardized way to communicate and to evaluate the plan of care. The in terms of grading, like 4 grades of abnormal cells. So we said we classify according to the anatomic site classification, according to the histology grading, or according to the staging, which is the extent of the disease, the staging, which is the last one, 4 grades of abnormal cells. So an example of that would be the grade 1, for example. Cells differ slightly from normal cells, which is, in other words, we call it mild dysplasia. And the cells are well differentiated. That's the low grade. So that's a grade 1. Grade 2, cells are more abnormal, like moderate dysplasia, and moderately differentiated, which is intermediate grade. And grade 3, which is the cells that are very abnormal, severe dysplasia, and poorly differentiated, high grade. Grade 4 cells are immature and primitive, which is the anaplasia, and undifferentiated. So the anaplasia, which is anaplastic, we call anaplastic cell, anaplasia, anaplastic cell, which is the cell doesn't is different in terms of the size and morphology and shape and appearance. As you compare it to the parent cell, it's very different: size, appearance, everything, and it's undifferentiated. It's unable to perform the function which was supposed to be performing. Clinical staging classification. So classifying the extent and spread of the disease is termed staging. Classifying the extent and the spread of the disease. So this classification system is based on the anatomic extent of the disease rather than on cell appearance. So it's more based on the progression of the disease, progression or disease as it progresses, and the extent of the disease. Well, although that there are similarities exist in the staging of various cancers, there are many differences for specific types of cancer. Clinical staging has been used as a basis for staging a variety of tumor types, including cancer of the cervix, the Hodgkin's lymphoma. Some cancer or malignant diseases like leukemia, for example, do not use this staging approach. So this staging approach is not being used, or irrelevant, or it's not it's not used in certain diseases or malignant diseases like leukemia. The clinical staging classification system, it determines the anatomic extent of the malignant disease processed by stages. So the clinical staging classification system determines the anatomic extent of the malignant disease process by stages, like which goes from 0 to 4, stage 0 to stage 4. And then we have the TNM classification system. I believe that we covered also this briefly in pathophysiology class. And we said that the TNM, which is, classify the tumor based on 3 components, which is the tumor size T, and then N, which is the spread of lymph nodes, and if there is any metastasis, which is under M. And goes for like, T 0, 1, or 2, N 0, 1, or 2, and then the M 0, 1, or 2. So the TNM staging cannot be applied to all malignancies, like leukemias, as you said. They are not solid tumors. Therefore, we cannot use leukemia as a form of malignant disease or malignant tumor. I mean, malignant disease as leukemia. It's not solid tumors, and therefore cannot be staged by using these guidelines. Examples of the clinical staging, examples of diagnostic studies that may be performed to assess for extent of disease would include the radiologic studies, radiology such as bone and liver scan, bone scans, liver scan, ultrasonography, CTs, which is computed tomography, MRIs, and PET scan, which is the positron emission tomography, PET scans. All these are known to be, very effective in terms of diagnosing, in addition to the nuclear medicine as well. Staging, surgical staging, which is determined by the surgical excision or exploration or lymph node sampling. The surgical staging refers to the extent of the disease as determined by the surgical excision, exploration, or lymph node stage sampling. Like, for example, when we do the laparotomy and splenectomy, may be performed in like staging of Hodgkin's lymphoma. Hodgkin's lymphoma, they do laparotomy and splenectomy that will be performed in staging of Hodgkin's lymphoma. During the laparotomy or staging laparotomy, lymph nodes biopsies may be done. So they'll take biopsies from the lymph nodes and margins of any masses. And margins of any masses may be marked with metal clips, so they can use it for radiation therapy. Kind of like identifying the affected, or the affected area, or the masses will be identified by these metal clips. So it will be identified for during radiation therapy, so that's for effective radiation therapy. So it will target that, they will kind of, focus the radiation on the landmarks has been identified during that procedure. Exploration or exploratory surgical staging, which is like an exploration surgery, can be also used or being used, but they are less frequently used as non-invasive diagnostic technology becomes increasingly sophisticated. So we have nowadays the advent of these like advanced technologies and advanced devices and techniques and diagnostic technologies that kind of make these surgical interventions or these exploratory surgical staging to be less frequently used. So staging classification is not changed once established. So after the extent of the disease is being determined, so we know what's the extent of that cancer or disease, the stage classification is not changed. So after the extent of the disease is being determined, the stage classification is not changed. The original description of the extent of the tumor remains part of the record. If additional treatment is needed, or if treatment fails, is unsuccessful. Retreatment staging is done to determine the extent of the disease process before treatment. In addition to the tumor classification systems, there are other rating scales that can be used to describe and document the status of patients with cancer at the time of the diagnosis, for treatment and retreatment, and at each follow-up examination. We have something called like the CATS index of independence in activities of daily living, for example. The Kronskovsky functional performance scale, which are like two tools or two scales that would describe patients' functional performance. So the patient may experience fear and anxiety, as we have indicated or mentioned at the outset of the lecture. We said that when the patient has a possible diagnosis of cancer, it is stressful to the patient, to the caregivers, to the family. So it's a stressful time for the patient and the family. And patient may undergo several ways or methods for days and up to weeks of diagnostic studies. So patient will undergo all these different methods or diagnostic tools, diagnostic studies to diagnose the patient's cancer or disease. And during this time, there is also a fear of the unknown, maybe more stressful than the actual diagnosis of cancer. The unknown, which includes treatment modalities. Is the patient going to receive chemotherapy or radiation or both, surgical intervention? So all of these are like, be at this point, as patient is undergoing all these diagnostic studies for days or up, even take sometimes weeks. During that time, patient has the fear of unknown, which refers to or arise from the unpredictability, not knowing or unknowing the specific type of interventions or medications or therapeutic modalities patients going to receive. In addition to that, the stressful time and fear of unknown, patient may also be overwhelmed or confused by the need for multiple diagnostic studies and consultations. So help to coordinate care between multiple specialties. And when it comes to different specialists are going to oncology versus other specialists in other systems may be involved. So help to coordinate the care between these multiple specialists and provide explanations of the purpose of required tests, as well as special preparation needed for these specialists and their proposed diagnostic studies and diagnostic plans. Some facilities, they have the comprehensive oncology teams and services that are all housed in the same building, and that will help coordinate care among the cancer specialists. So all specialists will be all housed and all available in the same place. That makes sense that the patient will effort-wise and stress-wise and all of that will be eliminated. We can restrict it to the lower limit, and for better results as well. The outcomes would be even better. So that some facilities, as I said, they have the comprehensive oncology teams and services that all will be housed in the same building, and that will help coordinate the care among all cancer specialists. So manage your own discomfort. Um, there's some tips here, and we can say learn to recognize your own discomfort during difficult conversations and to avoid communication patterns that may hinder or preclude exploration of feelings and meanings, such as providing false reassurances. For example, when we say it's probably nothing, that's a false reassurance. Or sometimes we direct the discussion saying, let's discuss that later, for example. So we have to address the patients as being, patients' stressors and patients' concerns, patients' questions as being identified at the moment. Shouldn't be delayed, shouldn't be procrastinating to a later time. And not to be judgmental or providing reassurances like false reassurances, like you're saying it's probably nothing, or saying, or we trying to redirect the patient's conversational discussion, saying, let's discuss that later, for example, or giving some generalizations. Generalizing is not recommended, saying like, for example, everything feels this way, or everyone thinks or feels that way. Or sometimes we use what is called the medical jargon, or like medical terms, technical terms, that means you are distancing yourself as a practitioner from the patient. So try to use language, very simple words that patient can understand. If you start like talking or saying technical language, which is medical jargon, that's kind of mean that you are trying to distance yourself from the patient. So these self-protective strategies deny patients the opportunity to share the meaning of their experience. In addition to that, they can also jeopardize your ability to build the trust relationship, because that's the most important at the outset of any clinician or practitioner or patient relationship. The trusting should be there. So we have to build that trust at the outset of the relationship. So this can jeopardize your ability as practitioners to build that trusting relationship with your patients. Caring questions. Like, do you believe that it's possible to fix patients' fears by avoiding them? Or the first one, which is, what can you do if you're uncomfortable discussing patients' fears and concerns about cancer? So take a moment to have students discuss their own fears and concerns about cancer. Like when you have, like in the clinical scenario or in like in the hospital, I would, encourage the patients to talk about that, about the cancer, about suffering, about the death, to allocate resources, explore resources for them. So they will have support and they will have assistance. So resource allocation is another major concept or major significant component of the plan of care for patients with cancer, given the length of the treatment they're going to receive. And we know that the plan of care begins when cancer is suspected, not confirmed as a diagnosis. When cancer is suspected, then the plan of care will begin. And the diagnosis may follow up normal screening tests or when symptoms appear. So when the screening tests results or when the symptoms appear, so the diagnosis may follow after that. This is a positron emission tomography, which is the PET scan before treatment, which is A, showing metastases throughout the body. The PET scan after treatment, which is B, shows the effects of therapy. More radioactive material accumulates in the areas that have higher levels of activity. And this often corresponds to areas of disease and shows up as bright spot on the PET, on the PET scan. So when you see more radioactive material, it will accumulate these radioactive material will accumulate in the areas that have a high level of activity. So A, which is before treatment, which shows the metastasis, and B, after treatment, and the effects of therapy. Diagnosis of cancer. So biopsies involves histologic, which is histologic examination by a pathologist of a piece of tissue. So we send the weak size, we obtain a piece of tissue of affected cancer tissue or what is suspected to be a cancer tissue, and we send it for to the lab or to the pathologist to analyze it. So that's a histology, and the histologist will send a report. It can be done by a needle or aspiration, like fine needle biopsy, FMP, or it can be done by incisional procedure or excisional procedure. Many radiologic techniques may be used in conjunction with the biopsy procedure. So we can sometimes, we do the radiology in conjunction with the biopsy procedure, like CT scan, MRI, ultrasound guided biopsy, fluoroscopic assisted biopsy to improve tissue localization. So we can, use the radiology or radiologic techniques in conjunction with the biopsy procedures like CT and MRI and ultrasound guided biopsies. And that's to improve the localization of the tissue. Various types, different types of and sizes of biopsy needles available and are selected according to the type of tissue to be sampled. Is that a tumor in the forearm? Is that a tumor in the internal abdominal tumor, large, small? Is that breast tumor? So it depends on the tumor size. Tumor in terms of location and size. So there are various types and sizes of biopsy needles that are available and are selected according to the type of tissue to be sampled. Like, for example, we have FNA, which is fine needle aspiration. That can be or maybe accomplished with a small gauge aspiration needle that will provide cells from the mass for cytologic examination. We have also a large core biopsy cutting needles that will deliver an actual piece of tissue, which is a core tissue, large piece of tissue, that can be analyzed with the advantage of preserving the histologic architect of the specific specimen. So these are just specifics about the difference between FNA and fine needle aspiration and large core biopsy, for example. We have excisional biopsy, which involves the surgical removal of the entire lesion. We try to remove and excise the entire lesion with what is called excisional biopsy. With that also, as you remove the entire lesion, you remove the lymph node, the nodule, the mass. So at this point, if that's the case, which is excisional biopsy, therefore it is the therapeutic as well as diagnostic tool. So you are using that as a therapeutic. You are removing, excising the tumor or the lesion. At the same time, you are also sending that lesion to the lab for pathology or histology. So if the excisional biopsy is not feasible, you cannot do the excisional biopsy, then incisional biopsy, which is partial incision. Incisional biopsy will be partial incision, will be performed with small, with the special technique, but that's partially will be removed. As we continue to talk about diagnosis of cancer, the pathologic evaluation of a tissue sample is the only definitive means to diagnose cancer. So confirmatory diagnosis will be based on the pathology evaluation. Pathologic evaluation of the tissue sample is the only definitive means to diagnose cancer. All other different diagnoses or diagnostic tools or diagnostic measures or studies will be assisting, assist, aid, and the confirmation of but this is the only definitive mean to diagnose cancer, which is the pathologic evaluation. The pathologist examined the tissue for three different things, to identify three things. The pathologist will examine the tissue to determine whether it is benign or malignant. Will give us also number two will give us another piece of information, which is the anatomic tissue. That's what is the anatomy of that tissue from which the tumor arises, which in other words, which is the histology. And the third aspect of the information would be the degree of cell differentiation, which is the histologic grade, which is grading, in other words. And other information that can be also obtained includes the extent of the malignant involvement, like the size of the tumor, the depth of the tumor, will give us also the evidence of invasiveness, if there is an invasion to the extracapsular or lymphatic. In other words, if there's an invasiveness that involves the tissue, and adequacy of the surgical excision, positive, negative surgical margin status, and other pieces of information. Lots of information will be given, but these are the most important ones. And that report from the pathologic evaluation. So this slide talks about health promotion, how to prevent cancer. So Alan tells you she wants to be healthier. So what can you tell her about lifestyle changes to be adopted to prevent cancer? To prevent cancer. Or if not, then to be detected at early stage. Primary prevention, secondary prevention, and tertiary prevention. So primary prevention, prevent the cancer from being developed. So we identify the carcinogens and we prevent it. And then the secondary prevention, which is a screening phase, like cancer markers, diagnostic tools, and try to identify the cancer from early phase of early detection, or from even before it's being developed. That's a screening. So lots of examples of the health promotion in the book. Things that can be implemented in a plan of health promotion plan to prevent cancer, or at least lead to early detection of cancer in its early phases. Like when we talk about the exposure to the carcinogens, we have an endless list of carcinogens in our like in diet, in like drinks and environment. So we have to reduce or avoid exposure to known or suspected carcinogens and what is called the cancer promoting agents, cigarette smoking, sun exposure, two major ones. Diet in terms of eat balanced diet that include vegetables and fresh fruits, whole grains, adequate amount of fiber, reduce dietary fat and preservative, includes the smoked and salt cured meats, which in other words like the processed meat, because it contains large amounts of nitrite concentrations. Limit alcohol use, participate in regular exercise, and with a good or like moderate physical activity, frequent times a week, maintain healthy weight, obtain adequate, consistent periods of rest, eliminate, reduce, or change the perceptions of stressors, and enhance the ability to effectively cope with stressors. So stress management, or to eliminate the stressors and reduce them, change the even the perception of stressors. Physical examination, periodic, frequent, on a regular basis. To have a physical examination on a regular basis is one of the challenges for those who don't have access to care or don't have health insurances. And the list goes on in the book. So that's lots of tips there in the book about health promotion, how to prevent cancer or to detect it in its early phases or stages. So early detection and prompt treatment are responsible for increased survival rates. So increased survival rates in patients with cancer, how it can be augmented and increased is the early detection and prompt treatment of these cases or scenarios. Colonoscopy, for example, colonoscopy is important in reducing colon cancer mortality. So patients with colon cancer, the mortality rates have declined with the use or the proper use of colonoscopy as one of the most important diagnostic tools, and it's diagnostic and therapeutic, for some cases or scenarios that patients who have been gone for colonoscopy, once they identify any polyps, that will be removed, because these polyps in the future, in 10 years from now, they become they are benign now, but they can become cancerous or malignant. So colonoscopy is important in reducing colon cancer mortality, both by early detection of colon cancers and prevention. Because when we excise, remove the adenomatous polyps from adenoma, excision of the adenomatous polyps removal, excision, remove these polyps removed during the colonoscopy, that can aid in the early detection of colon cancer, because these polyps are benign at the moment, but in 10 years from now, they may become malignant. So colonoscopy is, other than it confirms diagnosis with colorectal cancer, but it is important in reducing the colon cancer mortality both by early detection of cancer and by prevention. And continue with health promotion. So just for sake of time, I'm just going to give you, the answer to the question, and you can read it in your own. The answer would be A, smoking cessation, given that the highest number of cancer deaths by site are forced, um, uh, which is cancer of the lung and bronchus, and smoking is the leading cause of lung and bronchial cancer. Cancer treatment. Cancer treatment, the goals: cure, control, palliation. Now, primary factors that determine whether or what kind of therapy is used are the tumor histology and staging outcomes. So the histology report and staging outcome determines the primary factor. They are primary factors for the treatment or determinants for the treatment. Other important factors are patient's physiologic status, like the presence of any comorbid or any other comorbidities or comorbid illnesses, patient's psychological status, personal desires like um, uh, active treatment versus palliation of symptoms, active treatment versus if the patient wants the palliation of symptoms. And so these factors influence the modalities chosen for treatment, what is called the treatment modalities or methods of treatment. These factors also influence how therapies are sequenced, which one first, second, third, and also it will affect or influence the length of time that treatment is prescribed. Is patients going to be prescribed the 10 sessions of radiation or 20, 30? Each can be used alone or any combination during the initial treatment or as the maintenance therapy, as well as in treatment if retreatment, if when retreatment, so you can repeat the same program or the same plan of care and therapeutic regimen again. So that's retreatment if the disease doesn't respond or recurs after remission. Recurrences results in retreatment. So these scenarios in which the patient's disease is not responding to the treatment. So you have to repeat the therapy. For most or many types of cancer, two or more of the treatment modalities, which is called multimodality therapy, or what is called combined modality therapy. More than one therapy, like chemo, radiation, and medications, for example. So two or more of the treatment modalities are used to achieve the goal of cure or control for a long period of time. So that's called multimodality therapy. So multimodality therapy has the benefit of being more effective because it takes advantage of more than one mechanism of action. You target the cells from different angles, from different ways or different methods or mechanisms, but that's often at the expense of great toxicity. This chart shows the goals of cancer treatment. Cancer treatment can be curative or control treatment, curative therapy or control treatment. some type of leukemia, for example, like acute promyelocytic leukemia, this type of leukemia requires the chemotherapy for months to years. Promyelocytic leukemia, acute promyelocytic leukemia requires chemotherapy for months to years. Takes sometimes up to several years of treatment to treat this specific type of leukemia. Testicular cancer, cancer of the testicles. It can be cured with a combination of surgery, chemotherapy, and radiation. So the time frame to consider a person cured may differ according to the tumor and its characteristics. When you say control, that is the goal of the treatment. Our plan or treatment plan, that's the goal, is to control. So our goal is to, the control is the goal of treatment plan for many types of cancer. But we try to control because we cannot completely treat the disease, or in other words, eradicate the disease. So control is the goal of a treatment plan for many cancers that cannot be completely eradicated, but are responsive to anti-cancer therapies and can be controlled for long periods with therapy. So can be controlled, but not completely eradicated, or in other words, completely like treated or reaching towards like complete treatment, but can be controlled. Example of controlled treatment will be like multiple myeloma, chronic lymphocytic leukemia. Evidence of tumor assistance, such as disease progression, may warrant consideration of changing to an alternative therapy. So we have to change the therapy. Evidence of tumor resistance. If the tumor is resistant, not responsive to the treatment modality, like disease, you started or initiated the treatment, then there is disease progression that may warrant consideration of changing the a different type of therapy, which is alternative therapy. So this is a scenario or a case study of a male discovers lump in the testicle and schedules appointment with the PCP. And after testing, diagnosed with testicular cancer, explain the three stages of cancer and what metastasis means. I believe that we touch upon all these on the stages briefly, maybe at the beginning we talk about the pathophysiology. When we said that the initiation, which is the first stage, which is the mutation and the cell's DNA structure following the exposure to the chemical or radiation or viral agent. The mutation may also be inherited. Promotion, which is the second stage, and the development of cancer, which is characterized by reversible proliferation of the altered cells. Progression, which is the final stage, which is characterized by the increased growth rate of the tumor, increased invasiveness, and the spread of the cancer to the distant site, which is in what is called metastasis. And metastasis, which is a multi-step process in which the tumor cells have to travel to distant sites, either using via the lymphatic or the hematogenous route, which is the blood. And most frequent sites of metastasis are lungs, bone, brain, liver, and adrenal glands. And this is applicable to this specific scenario, which is the testicular cancer, that it's the most frequent sites of metastasis for this specific type of cancer is to the lungs, bone, brain, liver, and adrenal glands. Now, there is something called palliative therapy, which is palliation goal. With palliation, which is a relief or control of symptoms and the maintenance of a satisfactory quality of life. What we attempt with palliation is patient to be like pain-free, and we attempt to um, increase, augment, improve, enhance the quality of life of the patient's life. So it's a relief or control of symptoms and the maintenance of a satisfactory quality of life, because these are the they are the primary goals of the palliation, rather than cure or control of the disease process. That's when it comes to palliative therapy or palliation. With palliative medicine or palliative treatment, there's an emphasis on minimizing treatment-related toxicity. We try to eliminate the toxic effects of using certain medications or treatments, or so that's under the underpinnings of this, or the philosophy of of palliation treatment, is to minimize the treatment-related toxicity to the largest extent possible. Patient should be pain-free, but at the same time, we should not be giving the patient, the treatments or medications that would result in toxicity or adverse effects or adverse reactions or negative effects. Examples of treatment in which palliation is the primary goal include using radiation therapy or chemo to reduce the tumor size and relieve subsequent symptoms, such as the pain of bone metastasis. That's an example of when we use palliative therapy. Genetic information is used to customize decisions about prevention, diagnosis, and treatment. So in the previous slide, when I talk about palliation, it's different from the end of life care. End of life care is different. That's completely different, phenomena. Palliation or palliative therapy is different than what is called the end of life care, which is end of life care, which is usually it's becomes a mandate for for late stage cancer, for the last stage of cancer. So back to the genetic information, which is used to customize decisions about prevention, diagnosis, and treatment. So the emerging trend in cancer care or cancer treatment, there's an emerging trend. It's personalized. It's the what is called personalized medicine, in which the patient's genetic information is used to guide decisions made about prevention. We can use that specific genetic information to customize or personalize the plan and use it to guide decisions to be made about the prevention, about diagnosis, about the treatment of cancer. And many of the diagnostic studies, like the tumor markers, the one that I mentioned earlier about the EFP, about the CEAs, about these cancer markers, the PSA, and diagnostic studies like genetic markers, the molecular receptor status, all of these are diagnostic studies. So many of these diagnostic studies that are useful in determining the treatment options for patients with cancer. So before this personalized, what is called personalized medicine, most patients with specific type and stage of cancer received the same treatment. We did not have that time. We did not have something called like individualized or personalized medicine. All the patients across the board were receiving the same treatment. However, some treatments work well for some patients and not as well for others. So with the increasing research, it was found that genetic differences in people and their tumors explained many of these different responses to treatment. So patients or responses to treatment was individualized or was found different and not the same in all patients. There are some differences. So by when we do or perform these type of genetic tests and analysis, then the treatments can now be personalized and individualized. There's something also called targeted therapy, which aims at the cancer-specific genes or proteins that contribute to cancer growth and survival. So the treatment with a targeted therapy depends on assessing whether the tumor has the specific target. And this is usually done by testing sample of the tumor obtained through a biopsy. So we get the biopsy, the result or report from the biopsy, then we can build on that or develop and determine what type of targeted therapy should be implemented. And pharmacogenetics, which is the study of the genomic variation associated with drug responses, and we did briefly tap on this in Adult Health 2 at the beginning of the outset of the course with the presentation on pharmacogenetics, which is the study of the genetic variation associated with the drug responses, the study of genomic variation associated with drug responses. An example of how the result of genetic testing can be applied to the use of cancer drugs are presented in one of the in the chapter in the chapter 20 in the book. You'll find some of these differences in terms of the results of the genetic testing and how it's specific medications would work on specific types of cancer and so forth. So, for example, the Zelboraf is Zelboraf, one of the cancer meds. This drug is used to treat patients with metastatic melanoma. So, however, this medication, it's the only indicated medication for the treatment of patients with melanoma whose tumors express genes mutated or mutations with specific mutations. You didn't need to know these specific mutations, but there are specific mutations that this drug, which is the Zelboraf, Zelboraf, that this drug is used to treat the patients with tumors or whose tumors express a gene mutation, and there is two different names for these mutations. But there is a methodology and there is I would say this is one of the new sciences in terms of the implementation of the pharmacogenetics in the treatment of patients with cancer. Now, despite the promises of personalized cancer treatment that were just mentioned in the previous slide, despite the promises of the personalized cancer treatments, not all types of cancer have personalized treatment options. So this kind of methodology doesn't apply or won't be applicable to all different types of cancers. So genetic testing of the patient and tumor, the tumor sample, may be costly, and sometimes it's even time consuming. And I would say many insurance companies won't even cover the cost of these tests, and we did cover this piece of the genetic testing and the hindrance or the problems associated with with the, and especially the discrimination in the first or during the first two lectures or at the outset of the course in Adult Health 2. Genetic testing and the GINA Act and the discrimination that is associated with the genetic testing. in addition to also the cost, which is some personalized treatments like targeted treatment. It's costly and it can be very expensive. Surgery, that's another modality to, or therapeutic modality to treat patients, certain types of cancer. The consideration of the surgical intervention involves the assessment of tumor stage. So it depends on the stage of cancer. Then it will be, then we can determine if that surgical intervention is feasible or effective or would result in good outcomes or not. So including like local extension or metastasis that may limit the effectiveness of surgery. So consideration of consideration of the surgical intervention involves the assessment of tumor stage, which would include the local extension or metastasis that may limit the effectiveness of surgery. Now, in addition to the assessment of the tumor stage, also the technical feasibility of the surgical resection. The technical feasibility of the surgical resection. We also have to take into consideration the comorbidities. If the patient has another comorbidities, all of these may affect may influence the surgical risk and also the expected post-op functional outcomes. So that's why we have to consider all these factors before we plan or we implement, we develop the plan when it comes to surgical intervention. To take into account all these factors, which is the assessment of the tumor stage, technical feasibility of surgical resection, comorbidities, because all will be expected, and also in addition to that, expected post-op functional outcomes. Is that surgical intervention is going to result in positive post-op functional outcome or not? So that will be another, like one of the factors that when we determine, to be the surgery to be part of the treatment plan or not. So the objective of surgery is to remove all or much of the resectable tumor. So if that tumor is resectable, means can be excised, can be removed surgically, then the objective of surgery is to remove all or much of that resectable tumor as possible. But at the same time, we have to preserve and spare normal tissue. So just removing the affected or the cancerous tissue. Prevention, we talk enough about the prevention. Examples of prevention, this pertains to surgery, surgical therapy. An example of that, there are very limited implications or applications for the specific, for surgical intervention, as can be done as for prevention. Patient who have like polyps, for example, we said colonoscopy, and then adenomatous familial polyposis, which is the polyps, they may benefit. So patients with this specific colorectal cancer, because there are two different types of colorectal cancer, CRC. One of them is called adenomatous familial polyposis, AFP. This type of colorectal cancer, patients with this type, adenomatous familial polyposis, they may benefit from the total colostomy. So when we do colostomy for them, or when we perform the colostomy to prevent colorectal cancer, this is before the disease had started. So that's before, that's an early or preventive measure, preventive surgical intervention, we call it preventive surgical intervention. So patients with the EFP, one type of CRC, colorectal cancer, they may benefit from the total colostomy as preventive measure to prevent colorectal cancer. Another example of that would be like this usually would do it mostly. You will see it in celebrities and, people who are like, rich people, because that's kind of expensive. And I would say that the insurance companies would not support that or cover it because that's preventive measure, that the individuals who have genetic mutations of the BRCA1 or BRCA2, because they are predisposed and they are at risk for, to develop the breast cancer. So they may have a strong family history of early onset of breast cancer. They may consider the option of prophylactic mastectomy. That's another example of preventive measure in terms of surgical therapy. Prophylactic mastectomy, that's in individuals who have genetic mutations of the BRCA1, BRCA2, and have a strong family history of early onset breast cancer. They may consider that option of what is called the prophylactic mastectomy. These are like two examples of preventive surgical interventions. Cure and control. Other times it may be necessary for the patient to receive what is called the neoadjuvant, which is treatment before surgery. So before the surgical intervention, we will start, or patient will receive what is called neoadjuvant. Chemotherapy, or can be radiation therapy, because we want to reduce the tumor size or to reduce the tumor burden. And also we can improve the surgical outcome. So doing that before surgery, given patient or prescribing or patient receiving that neoadjuvant treatment before surgery, chemo, radiation therapy, to reduce the tumor burden and to improve surgical outcome. Examples of surgical procedures used to cure or for cure or to control cancer include like radical neck dissection, mastectomy, orchidectomy, which is the surgical excision of the testicles, thyroidectomy, removal or surgical excision of the thyroid, nephrectomy, excision or surgical removal of the kidneys, and hysterectomy and oophorectomy, which is the excision and surgical removal of the ovaries. Hysterectomy, uterus, oophorectomy, which is ovaries. These are certain types of specific types of surgeries used for cure or control of cancer. We still under surgical therapies, supportive and palliative care. The late effects of treatment or symptoms from metastatic cancer may necessitate surgical intervention. And we have examples of that. The late effect of the treatment or symptoms from metastatic cancer may require surgical intervention. Examples of this would be colostomy for the relief of bowel obstruction, laminectomy for the relief of spinal cord compression, colostomy for the relief of bowel obstruction, laminectomy for the relief of spinal cord compression. Or sometimes they do to relieve pain or pressure of the nerve. They do something called debulking of tumor. Debulking of tumor to relieve pain or pressure. Antineoplastic therapy, which is use of chemicals as intravenous, as systemic therapy for cancer. And historically speaking about the chemotherapies, like back in the 1940s, the nitrogen mustard, a chemical warfare agent used in World Wars One and Two, it was used in the treatment of lymphoma and also in acute leukemia. And then after that, in the 1970s, the chemotherapy was established as an effective treatment modality for cancer. So chemotherapy can offer a cure for some types of cancer, control for other types of cancer for long periods of time, can cure completely for certain types, can control for other types. And in some instances, it offers only palliative relief of symptoms. And that would be when, or in certain types of cancer, when cure or control is no longer possible. Chemotherapy, it's effective against the dividing cells. So the two major categories of chemotherapy drugs are cell cycle phase, non-specific, and cell cycle phase specific drugs. And we have a list of all these drugs in the book, talks about include all the different types of chemotherapy. And in that, under that classification of chemotherapy drugs or chemo, call them chemo, they are classified, there are different criteria for this classification, molecular structure, mechanism of action. Now, each drug in a particular classification has many similarities. However, there are major differences in how the drug works and the unique side effects associated with drugs in each class. And we don't usually cover this in pharmacology class. So that was one of the intentions or the reasons to include it and talk about it in this. And I mean, to have this lecture, so we'd have at least coverage for the chemotherapeutic agents, given that it's not usually covered in pharmacology class. So we have different types of classifications when it comes to chemotherapeutic agents or drugs. We said cell cycle phase non-specific, like what is called under that, we will have what is called the alkylinetic from alkaline, alkylating or alkylating agents, platinum drugs, like 2 out of 4 subclassifications under the cell cycle phase non-specific. And then under the cell cycle phase specific, we have something like anti-metabolites or the mitotic inhibitors. You'll find all of these different classifications and subclassifications in the book. Anti-metabolites and the mitotic inhibitors. So the drugs may be absorbed through the skin, inhalation during preparation, transportation, and administration. And this slide provides like a great deal of nursing implications when it comes to handling chemotherapeutic agents. A significant, a very important slide because and not a lot of content, but at least just to guide you to the book to study about the nursing implications and how to, especially it says here, the drug will be absorbed through the skin, which means that never handle chemotherapy without gloves. Inhalation during preparation, transportation, administration. So this implies a lot of nursing interventions while handling chemotherapy. So drugs may pose an occupational hazard to healthcare providers, including nurses, especially when they do not follow the safe handling guidelines. There are Maybe also some risk in handling the body fluids and excretions of persons receiving chemotherapy immediately following the administration, about for up to like 48 hours or in the first 48 hours. So there's a risk also in handling the bodily or body fluids and excretions of persons, patients receiving chemotherapy immediately following administration for 48 hours. Implies and also will guide us to a lot of precautions and specific nursing interventions to be taken or implemented to prevent that transmission or that exposure by the health provider, especially here nurses. And we have guidelines for the safe handling of chemotherapy agents or therapeutic agents, which was developed by OSHA and by the Oncology Nursing Society. Methods of administration, oral, intramuscular, and intravenous. Intravenous is the most common one. And definitely, we recommend that to be administered via a CVAD, central venous access device. And most likely, post-discharge, patient will be receiving that via the what is called the implanted port, which is the device that is implanted under the skin and feels like a pacemaker under the skin, upper chest, and that's the intravenous access device, but it's it's the implanted port. So the chemotherapy can be administered, we said, by multiple routes. With the advances in drug formulation techniques, more oral chemo. Now we have more chemotherapy agents that are available than in the past with the advances in drug formulation techniques. But the intravenous, the IV, route is the most common method of administering chemotherapy. So when you say chemo, automatically you refer to intravenous, most likely. Because with the oral agents, the patient needs to be taught and educated about the storage of the drug and the side effects of the drug. Chemotherapy and CVAD or central venous access device administration. And the CVAD are placed in large blood vessel, as we know, and that will permit frequent, continuous administration of chemotherapy. And or sometimes patients receive chemo or immunotherapy or targeted therapy, and sometimes other products, and even blood products, blood transfusions. So we can avoid, by having this access device, we can avoid the multiple venipunctures for vascular access, and we can minimize associated physical discomfort and complications and emotional stress and risk for infections and infiltration. Chemotherapy. Extravasation injury due to chemotherapy. Extravasation, which means that the drug infiltrates through the blood vessel, especially if you are infusing that via small veins or small blood vessels. That's why we recommend central venous access for chemotherapy. So major concerns associated with the IV administration of anti-neoplastic drugs, which is a chemotherapy, include venous access difficulties, infections, which is device or catheter related infection. And in addition to this, figures showing the extravasation. That's another risk or major concern. Infections, access difficulties, and extravasation, which is the infiltration of the drug into the tissue surrounding the infusion site. the drug infiltrates into the surrounding infusion tissues surrounding the infusion site, which will cause its local tissue damage. So it is extremely important to monitor for and promptly recognize symptoms associated with extravasation and take immediate action if it occurs. When we say vesicant, means the drug or chemotherapy which will result in extravasation or which will cause the extravasation. So it is extremely important to monitor and promptly recognize symptoms associated with extravasation of a vesicant and to take immediate action if it occurs. Chemotherapy, regional administration, and so several regional delivery methods have been developed. We have intra-arterial, intraperitoneal through the peritoneum, intrathecal, spinal cord or spinal canal, intraventricular or intravesical bladder chemotherapy, which is into the bladder. The intra-arterial, which is this method has been used for the treatment of osteogenic sarcoma, for example, which is the cancer that affects the bone, osteogenic sarcoma, cancer of the head and neck, bladder, cervix, melanoma, liver cancer, or the metastasis of the liver cancer. So that's the intra-arterial method, which is for the treatment of osteogenic sarcoma and other types of cancer. Head and neck, bladder, cervix, melanoma. So the intraperitoneal, which is the chemotherapy, which is generally infused into the peritoneum, the abdomen, in 1 to 2 liters of fluid, and we allow the fluid to stay in the peritoneum for about 1 to 4 hours. So it's a drug, chemotherapy, that will be diluted in 1 to 2 liters of fluid and then will be infused and will stay in the peritoneum for about a period of 1 to 4 hours. And then following the dwell time, which is when it stayed for 1 to 4 hours, then the fluid will be drained from the peritoneum. So that's one of the modalities called intraperitoneal chemotherapy. So the first one, intra-arterial, we'll give example of that treatment of osteogenic sarcoma and other cancers or types of cancers. And then the second one, intraperitoneal, which is the chemotherapy infused into the peritoneum and drained after that. Intrathecal or intraventricular. And this one is commonly used for cancers that metastasize to the central nervous system. Difficult to treat because the blood-brain barrier often prevents distribution of chemotherapy to this area. Very difficult for the chemotherapy to be infiltrated or to be transported or to be distributed to the brain and spinal cord because of the blood-brain barrier will prevent that. So the intrathecal or intraventricular will be commonly used method of administration of chemotherapy for cancers that metastasize to the central nervous system, CNS. The intrathecal chemotherapy involves a lumbar puncture, spinal tap, an injection of the chemotherapy into the subarachnoid space, chemotherapy the side effects. So the chemotherapy induced side effects, and side effects affect or resulted from or result from the chemotherapy. They usually result or they are the result of the destruction of normal cells, especially those that are rapidly proliferating, such as those in the bone marrow, lining of the GI tract, gastrointestinal system, and in the integumentary system, the skin and hair and nails. So the adverse effects are classified as acute, delayed, or chronic. The acute toxicity occurs during the immediate phase, which is immediately after drug administration, and it includes anaphylaxis or anaphylactic and hypersensitivity reactions, or extravasation, as we have seen in the previous slide, when the drug has infiltrated to the tissues and burned the cells and damaged the cells, the tissues, or anticipatory nausea, vomiting, cardiac dysrhythmias, all are acute toxicity due to the immediately after the drug administration. Delayed effects are too many, numerous, and include delayed nausea, vomiting, mucositis, falling of the hair, which is alopecia, skin rashes, bone marrow suppression, which will be indicated in the low white blood cells, leukopenia, decrease in white blood cell count, bone marrow suppression with leukopenia, and altered bowel function like diarrhea, constipation. Chronic toxicities would involve the damage to organs like such as heart, liver, kidney, lungs. And these chronic toxicities can be either long-term effect that they develop during or immediately following the treatment and persist, or late effect that are absent during the treatment, but they manifest later on. And some of the side effects that fall into more than one category will, like, for example, like nausea and vomiting, they fall in more than one category, like the acute and delayed and chronic. And this is like the prominent adverse effect of all different types of chemotherapy is that patient will have nausea and vomiting, and that's persistent, and that's kind of all the time, like consistent and persistent with all patients across the board who receive chemotherapy. Drugs given in combination, chemo. So when chemotherapeutic agents or chemotherapy agents are used in combination, which eventually is going to result in an increase in toxicities. So the patient can experience more heightened, an increase in toxicities. So the drug regimens are selected based on the evidence supporting their use in specific cancers. And sometimes they are customized to meet the needs of the individualized patient. Chemotherapy is most effective when the treatment burden is low. The tumor burden is low, the tumor like size, the tumor's severity is low, or when the therapy is not interrupted and the patient receives the intended dose. So at times that we customize the treatment plan, so it is customized to meet the needs of the individual patient. So the chemo is most effective when the tumor burden is low, therapy is not interrupted, and the patient receives the intended dose. Some of these toxicities are not reversible. So that's why as nurses, we have to differentiate between the side effects that are tolerated from those are not so tolerable side effects, and side effects who are reported as being toxic. So some, reports will indicate or should indicate if we know of what type of side effects is that, is it acute, is it delayed, is it chronic, and because some toxicities, they are irreversible. Patient will continue to have them all the time. This, I believe that we covered this TNM, which is the classification, the TNM classification system in previous section, or in the other slide. We talk about the classification of the cancer and the tumors. We said that TNM classification system uses the 3 parameters, which is the tumor size and invasiveness, which is T, presence or absence of regional spread of lymph nodes, which is the N, and then metastasis to distant organ sites, which is the M. So this patient is T2N1M0, which means that the T2 means the cancer has spread to blood or lymph vessels near the tumor. N1 means there is a spread at least 1 lymph node, but no lymph node is larger than 2 centimeters in any dimension. And the M0 means there is no distant metastasis. The second treatment in cancer, the second modality in the cancer treatment is radiation therapy. So along with surgery, radiation therapy is one of the oldest methods of cancer treatment. It was first used by one of the medical students back in the 1896 for the first time to treat an ulcerating breast cancer. Back the first time was used by medical student. I used it in 1891. No, I'm sorry, 1896. Although the patient responded locally, she died later from the metastasis of the disease process. So the observation that radiation exposure caused tissue damage led the scientists to explore the use of radiation to treat different types of tumors. Because they found from scientific endeavors, from research, found that the hypothesized association identified or determined that if radiation exposure resulted in the destruction of a highly mitotic skin cells, it could be used in a controlled way to prevent the continued growth of cancer cells. Because that was the underpinning theory behind the use of radiation therapy. If radiation exposure resulted in the destruction of the highly mitotic skin cells, then it could be used in controlling or in a controlled method or controlled way to prevent the continued growth of the cancer cells. So it wasn't not until the back in 1960s when the sophisticated equipment and treatment planning had facilitated the delivery of the adequate radiation doses to treat different types of tumors. So too many cancers or different types of cancers, patients with cancer, they receive radiation at some point of their treatment. Now, different types of ionizing radiation has been implemented and used to treat cancer, including the electromagnetic radiation, which is, we use with this one, the gamma, X-rays and gamma rays, both, with the electromagnetic radiation. And the particulate radiation, which in which they use the alpha particles, electrons, neutrons, and protons. So two main types of radiation, either the electromagnetic radiation or the particulate radiation. And each one of these, they use different types of rays. Gamma rays, X-rays, electrons, alpha particles. So the technology advances have expanded and then refined the sources and the methods of delivering radiation therapy. Thus, it will kind of offer the more variety, more and accurate and less invasive radiation treatment options. So it became less invasive and more accurate in terms of targeting the exact malignant cells, and it will only attack the cells with minimal effect on the healthy cells. So most radiation centers here in the US, currently they use a mega voltage linear accelerator technology, the specific technology being used for a while. And all the centers, they use this specific technology. It's a safer technology for the treatment, with using the radiation. So we have low energy beams and we have high energy beams radiation therapy. So as the radiation beams passes through the treatment field, energy is deposited. So technically, all cancer cells could be killed with radiation given a high or produced in high enough doses. However, to avoid tox, because we have to avoid the serious toxicity, we cannot just give the patient the high, radiation and to kill, because that's going to result in high or a serious toxicity. So to avoid the serious toxicity and long-term complications of the treatment with this specific, this radiation, the radiation therapy to surrounding healthy tissues must be limited to the maximal tolerated doses or dose for that specific tissue. So as we deliver that radiation beam or radiation therapy to the affected, to the malignant tissue, we have to take an account or consideration that the effect on surrounding healthy tissue must be limited to the maximal tolerated dose. To the maximal tolerated dose, the least can affect the healthy tissue. So we can minimize and and restrict the toxicity. So once the total dose to be delivered, which is prescribed, determined, once that total dose to be delivered is determined, to be delivered, to be administered, then the dose is divided into daily fractions. Let's say, this specific amount of radiation should be should be effective for this specific tumor. Then this amount will be divided by how many days, and these fractions, which means the fraction is like a daily session. 20 sessions, 30 sessions, 15 sessions. So it depends on, divide that amount over the days, and that will be radiation session. And under radiation therapy, there's something called simulation, which is a process by which radiation treatment fields are defined, filmed, and marked out on scan. So the simulation determines the orientation and size of radiation beams and the location of the field shaping blocks, and allow for outlining of the field on the patient's skin, because we can identify, delineate, we can limit the space and the specific area, specific landmarks per se on the skin, so that we know where to deliver or to target the beam or the radiation to. And there are specific criteria and measurements when it comes to radiation and the simulation for radiation. Like the treatment volumes include certain numbers. It's like, outside the scope of the class to talk about that, like, GTV, CTV, and other parameters. But there are specific parameters that will be included as we do these kind of simulations, because the simulations determines the orientation and size of radiation beams and the location of the field shaping blocks, and will allow to outline the field on the patient's skin in which it will be targeted by the radiation therapy. Small tiny like markers, we call them like small tattoos, may be placed to ensure that the patient position is precisely reproduced on a daily basis, and that will like a permanent, it will stay at least for the for the term of the therapy, for the radiation therapy. Or like small tattoos will be placed to ensure that the patient position is precisely reproduced on a daily basis. An example of patient position in a simulator, which is a diagnostic X-ray machine that recreates the actions of the linear accelerator and the radiation fields, are marked on the patient's skin. So in this example, the head holder and immobilization mask may be used to ensure accurate positioning for daily treatment of head and neck cancer. That's an example of patient with head and neck cancer will be receiving radiation on a daily basis for several days. Each day will have a session. So the head holder and immobilization mask may be used to ensure accurate positioning for daily treatment of this type of cancer, which is head and neck cancer. Radiation is used to treat a carefully defined area of the body. So the radiation only has an effect on tissues within the treatment field. It is not appropriate as the primary treatment for systemic disease. Localized effect. It doesn't have a systemic effect. Systemic disease like leukemia, it's not going to work. Because leukemia, it's not localized from a specific like in tumor. It's disease of it's a cancer of affecting the blood or the blood-borne forming organs or cells, like a bone marrow. Transplant would be the most effective for like leukemia, for example, not radiation. So radiation only has an effect on tissues within the treatment field, and it's not appropriate, would not be good for the primary treatment, or it's not good or effective treatment for a systemic disease like leukemia, an example of that. External radiation, which is teletherapy, most common radiation treatment. So radiation can be delivered externally, which is known here as the teletherapy, or external beam radiotherapy, or we can also administer it or deliver it internally, brachytherapy. So brachytherapy internally, teletherapy externally. So radiation, this is just an example showing a linear accelerator, which will generate the ionizing radiation from the electricity and can have multiple energies. And that's the most commonly used machine for delivering external beam radiation. So to deliver the external beam radiation, this would be the most common one. Is called a linear accelerator, which will generate ionizing radiation. The internal radiation, which is a brachytherapy, in which that there will be implantation or insertion of radioactive material into or close to a tumor, into a tumor or close to the tumor. So brachytherapy, which is internal radiation treatment, it consists of implantation or insertion of what we said, the radioactive material. Either will go directly into the tumor, which will involve the tissues, which is like interstitial tissues, or in close proximity adjacent to the tumor, like intracavitary or intraluminal. Two different methods of implanting the brachytherapy into or adjacent to the tumor. And it's sometimes we use that in combination with external radiation. External and internal radiation commonly used in combination. The implanted just brachytherapy may be permanently placed, like sometimes when we, such as the implantation of radioactive seeds or mesh implantation. Sometimes it's implanted temporarily, so temporary or permanent placement or implantation of these brachytherapy. Temporary seeds may be delivered through catheters to the target site for specific or specified amount of time, and then will be withdrawn so that the patient is not radioactive after the procedure. These are called temporary seeds, which will be delivered through catheters to the target site for specified amount of time, and then will be withdrawn so that the patient is not radioactive after the procedure. The patients with the temporary implants are radioactive only during the time the source is in place. When the source is in place, the implanted radiotherapy, the patient with that temporary implant, they are radioactive only during the time when that source of radioactive material or implant is in place. Now, in patients with permanent implants, because the sources have fairly short half-lives and are weak emitters of radiation, they don't emit like strong radiation, the radioactive exposure to the outside and others will be very low because that's permanent. They're not going to implant a permanent implants or radioactive implants that is going to be harmful to others next door, who live with the patient. So in patients with permanent implants, because the sources have fairly short half-life and are weak emitters of radiation, then the radioactive exposure to the outside and others will be very low. So we have to, as healthcare providers, we should be very, very careful, or we have to understand the difference between temporary versus permanent, and the principles of the time, distance, the shielding, precautions and guidelines, how to protect our professionals and the public from this type of radiation if that's implanted. So information is important and critical when it comes to implanted radiation, given the risk of exposure to this specific radiation. And there is a specific principles called ALARA, as low as reasonably achievable. So the principles of as low as reasonably achievable and time, distance, and shielding, they are vital and critical to the healthcare providers for their safety when they care for, for a person with these type of internal radiation implants. The common side effects and that include or covers all the nursing management and nursing implications and the treatment modalities, the different modalities to treat patients with cancer. Our role is critical in helping the patient, educating the patient, and help the patient to deal with the side effects of chemotherapy and radiation therapy. Example of that would be like educate the patient about their treatment regimens, about supportive care options like antiemetics, antidiarrheals, medications to counteract these side effects, and what to expect during the treatment or the course of treatment to decrease the fear and anxiety, reassurance, support, encourage patients to adhere to the treatment modality and enhance compliance with therapy, and also to guide the patient for self-management, because patients don't, you will go home or, most of that treatment will be, or the management will be on the patient's shoulders, so they'll be independently doing that on their own. So we will guide the self-management at home. The nursing management of the patient with cancer or who was receiving cancer treatment, it will encompass interventions to counter the effect of a lot of serious side effects like anemia, nausea, vomiting, anorexia, myelosuppression, which is the um, immunosuppression and myelosuppression, thrombocytopenia, which is the low platelet count, stomatitis, which is the inflammation of the buccal or mucosa in the mouth, diarrhea, constipation, skin reactions. All of these are expected side effects, and we have to handle that. There are some differences. So bone marrow suppression, which is most common side effect of chemotherapy, which is myelosuppression. The major difference in manifestations between radiation and chemotherapy is that with radiation, which is a local radiation, local therapy, only bone marrow within the treatment field will be affected. So the bone marrow within the treatment field will be affected. It's not systemic. It's not going to affect all bone marrow. On the other hand, whereas with chemotherapy, it is a systemic therapy. Radiation localized, affecting all the affected or the bone marrow that is being affected by radiation, but not systemic, not all bone marrow. Whereas the chemotherapy, because it's systemic therapy, then it will affect the bone marrow function throughout the body. So the chemotherapy has more detrimental effect on the bone marrow and the myelosuppression and the bone marrow suppression more than the radiation therapy. So in general, the onset of bone marrow suppression in relation to the lifespan of the blood cell type, like RBCs, white blood cells, platelet, The white blood cells, it's within 1 to 2 weeks, platelets 2 to 3 weeks, RBCs after 3 weeks. That's the onset of bone marrow suppression in reference to the use of chemo and radiation. For white blood cells, within like 1 to 2 weeks, they will show like decline in terms of like significant decrease in white blood cells, leukopenia, less than 5,000. Platelets within like 2 to 3 weeks after the initiation or the onset of the initiation of the treatment, bone marrow suppression will be present or evident in 2 to 3 weeks after. Platelet count will drop less than 140,000 or 150,000. RBCs after 3 weeks will drop, or decrease. The neutropenia is the most common in patients receiving chemotherapy. So patients who receive chemotherapy, the most common side effect or type of bone marrow suppression will be in the neutropenia, significant decrease in neutrophil count. Fatigue is nearly universal symptom affecting most patients with cancer. It is commonly reported by patients as the most distressful of treatment-related side effects. So it may persist long after treatment has ended. Anemia is one cause of fatigue. Other causes of fatigue may be related to the accumulation of toxic substances that are left in the body after cells are killed by cancer treatment, or the need for extra energy to repair and to heal the body tissue damaged by the treatment, or maybe that's due to lack of sleep caused by some chemotherapeutic agents or therapies. So these are causes why the patient would result with anemia is one cause of fatigue. Other causes, we said, it could be the accumulation of toxic substances, the need for extra energy for the cells to repair itself, or lack of sleep and sleep deprivation caused by the chemotherapy drugs. So we encourage patients to maintain as much as they can exercise and activity as tolerated that will limit these side effects to an extent. And also it will help in managing fatigue. Gastrointestinal effects, GI. The intestinal mucosa is one of the most sensitive tissues to radiation and to chemotherapy. So the GI effects, which would include nausea, vomiting, diarrhea, mucositis, anorexia. The nausea and vomiting are common sequelae of chemotherapy agents. Some patients exercise the different modalities to treat the nausea and vomiting, but others would experience what is called the anticipatory or delayed nausea and vomiting. Anticipatory or delayed nausea and vomiting. In terms of the onset of vomiting, the vomiting may occur within like an hour of chemotherapeutic agent administration. Once we start chemotherapy, infusion or administration, then within like an hour, patients start to complain of vomiting or to experience vomiting. And for radiation, it's usually few hours after radiation therapy to the chest, abdomen, and that may persist for 24 hours or longer for the radiation. So for chemotherapy, it's like an hour, within like an hour of chemo administration, patient will begin experiencing vomiting, and a few hours after radiation therapy, especially to the chest or abdomen, and that may persist after radiation for about 24 hours or longer. Anorexia, which is loss of appetite, that's the most common occurrence of side effect in patients with cancer. And it is the side effect of the cancer itself, as well as from the treatment for cancer. And in terms of the etiology or what's causing the anorexia, it may be related to the inflamed mouth or esophagus, which create difficulty chewing or swallowing. Or sometimes it's stress-related or emotions such as anxiety or depression. So we have to teach the patients to examine the mouth and oral cavity and maintain oral care routine as much as they can. In addition to that, dental work, dentalist exam or dental work should be performed before the initiation of these therapies. Patient may develop a loss of taste or dysphagia. And there are other nursing interventions pertains to this side effect on the textbook. Skin reactions. Especially with radiation, this skin effects are local and occurring only in the treatment field, very localized from radiation. So this is called radiation-induced skin changes. It can be acute or chronic, and that depends on the area irradiated, the area being used for targeted by radiation, and the dosage of radiation, the technique used in radiation. So skin reactions are particularly evident in areas of like skin folds or where the skin is subjected to pressure, like behind the ear, gluteal folds, perineum, breasts, collar line, or bony prominences. What's shown here in that figure on this slide, which is the dry desquamation, the erythema is an acute response followed by what we have, what we see in this slide, which is dry desquamation. So erythema is an acute response followed by the dry desquamation. The dry reactions or like dry desquamation is uncomfortable for the patient, and that would result in like pruritus and itching and pruritus. So it's recommended that we lubricate the lubrication of the dry skin with non-irritating lotion or emollient. Aloe vera would be the best as a non-irritating lotion emollient. So any material that does not contain any metal or alcohol or perfume or additives, because all of these will be irritating to the skin. So some scenarios like this, you'll find that it's a wet desquamation. So if the rate of the cell sloughing is faster than the ability of the new epidermis or epidermal cells to replace the dead cells, then you will see a wet desquamation like this. It will occur with exposure of the dermis and what's called weeping of serous fluid. The serous fluid will be secreted due to this process. So the wet reactions or the areas of the wet disc formation should be kept clean and protected from further damage. It is painful, and pain management is required. For these specific skin reactions, we prevent infection, facilitate wound healing. So under the nursing implications or interventions, do not use heating pads or ice packs or hot water bottles in the treatment field. Pulmonary effect can be progressive and irreversible. Cough, dyspnea, pneumonitis, pulmonary edema. Both modalities, which is the chemo and the radiation, they have the potential to produce pulmonary tissue damage that is irreversible and progressive. Distinguishing between the complications of treatment and those related to disease is very challenging to professionals to figure out if that's, that had resulted from the disease process or that could be the treatment or cancer treatment related as a side effect or adverse reaction. Sometimes it's very challenging to, to pinpoint or to identify, to distinguish between these two. The immediate pulmonary effect of radiation can be alarming to patients because that may mimic the symptoms, cough, dyspnea, that precipitated the cancer diagnosis, because patient already diagnosed with, with lung cancer, for example. So they will have dyspnea, they will have, the cough, and that persistent, and that's continuous. So that's sometimes we say that the immediate pulmonary effect of radiation can be alarming to patients because they may mimic the symptoms, such coughing and dyspnea, that were precipitated the cancer diagnosis. In terms of the inflammation effect or the inflammatory reaction, the pneumonitis, the pulmonary fibrosis, pulmonary edema, the interstitial fibrosis, they are produced by an inflammatory reaction or destruction of the alveolar capillary endothelium. And that's all possible pulmonary effects. In response to the cardiovascular effects, both therapeutic therapies, modalities, radiation and chemotherapy, they have the potential to produce irreversible and progressive cardiac toxicities. Common toxicity, cardiac toxicity, would be pericardial effusion. Certain medications, specific meds or chemotherapies, therapeutic agents, which belong to the classification of the anthracyclines, they can cause cardiotoxicity, like EKG abnormalities, dysrhythmias, left ventricular dysfunction, heart failure. They are associated with the anthracyclines as one of the classifications of chemotherapies. So what we recommend is to have a baseline and then periodic EKG to monitor the left ventricular function during the treatment, so we can monitor any changes in the cardiovascular function. Cognitive cognitive effects. Cognitive effects can happen at any time during cancer, especially after treatment. And this alteration in the mental function, commonly described by patients as mental cloudiness or fogginess. And we sometimes, and commonly actually, practitioners, they call that chemo brain. Patients can experience thinking and memory problems, although most of the time the brain will usually recover over time. The effects can last a short time or last for years. For some patients, the effects can be so severe that patients may be unable to be involved in any activities that require the mental effort, such as like school, work, social activities. Reproductive effects. The reproductive effects occur most often when reproductive organs are included in the radiation and the treatment of the radiation treatment, I mean, when they are involved in the radiation field and with the use of what is called the alkylating agent, alkylating agent, which is some type of or classification of the chemotherapeutic agents, alkylating agents. Fertility preservation should be addressed as we counsel, as we talk to the patient and the partner, so that fertility preservation should be addressed prior to the start of any cancer treatment, like pre-harvest, pre-treatment, harvesting of a sperm, ova, or ovarian tissue that can be considered as part of the pre-treatment discussions and pre-treatment plans. In terms of the organs that are sensitive to radiation, testicles are highly sensitive to radiation, and the testicles should be protected with testicular shield. And we usually use a lid cover from the radiation, like the ones that we use in X-ray departments and cardiac catheterization labs, in which professionals, they will wear a lead apron, long one with the collar around the neck and below the knees, a long apron. It's lead, 25 up to sometimes 50 pounds lead apron here. So in this case, if the patient is receiving radiation and it's not the testicular cancer, then they should cover the testicular, or I mean testicles with the testicular shield when possible. Late effects of radiation and chemotherapy. And this slide talks about long-term sequelae of events or long-term effects. So radiation therapy or chemo, they can produce a long-term sequel months to years after the cessation of therapy. So after we stop the therapy, patient may experience these effects even after we stop the therapy, the chemo or radiation therapy, which can affect every body system. Like with radiation, the late radiation effects most commonly will be in specific cells. We call them the mitotic cells from mitoses, post-mitotic cells like the liver, kidneys, lung, heart, muscle, bones, connective tissue. And an example of that would be it ranges from highest to lowest. So an example of this would be like skin, what is called skin telangiectasias, which is like red marks or red strikes on the skin. Could be like strictures or fistula or necrosis. So it ranges, the changes on the skin or affecting the skin from just telangiectasias, like just red marks and red strikes, to strictures or fistulas or necroses. Other changes could be like lymphedema, like alterations of the lymphatic channels, especially the axillary lymph node dissection. After mastectomy with the removal of the lymph node, axillary lymph nodes, the dissection of these lymph nodes could result or contribute to what is called lymphedema. When it comes to chemotherapy, the cardiac toxicity, cataract, disease affecting the eye, cataract, arthralgia, which is painful knees, it changes in the endocrine system, renal insufficiency, hepatitis, osteoporosis, even dysfunctions that affect the cognition, neurocognitive dysfunction that could be related to late effect of chemotherapy. And the answer to this question would be C, which is the the explanation would be, or the rationale would be, the low sperm counts and loss of motility are often seen in testicular cancer or with cancer of the testicles before therapy is begun. So which implies some type of counseling in which that the nurse encouraged the discussion of issues related to the reproduction and sexuality, and we offer the specific suggestions and make referral for counseling. Immunotherapy, there are various types of immunotherapy to induce the chemical mediators like cytokines. Others would be like vaccines or some monoclonal antibodies. The monoclonal antibodies, all these drugs that end with MAB, so anytime you see a drug, chemotherapeutic agent, or drug to treat cancer, antineoplastic agent or chemotherapeutic agent that will end with MAB, MAB, which is the suffix MAB, MAB, that is what is called the monoclonal antibodies type. That's the most successful immunotherapy. It's not chemotherapy, but in this case would be the immunotherapy to treat cancer. So it's not chemo, it will be immunotherapy to treat cancer, which is the classification of immunotherapeutic agents that will end with MAB, MAB. So the and we know what is the antibodies, right? So the antibodies are the proteins produced by the immune system that bind to the target antigen on the cell surface. Because each antibody is specific to the antigen, to just one antigen, then the mechanism is used to develop the specific drug to treat cancer. So they use that kind of principle on that scientific base about the antigen-antibody reaction, and they develop this, what is called the monoclonal antibodies. So that mechanism, they use that or utilize that to develop the specific drugs to treat different types of cancer. And most of these, or many of these monoclonal antibodies, they are targeted therapies. So targeted therapies they are more selective for specific molecular targets than the chemotherapeutic agents or drugs, because chemotherapies has to be used systemic, it has a systemic effect. You have to be given intravenous, so it will affect, its effect will be systematic, or affects all the systems. So I'm sorry, it's systemic effect. But the targeted therapies, they are more selective for specific molecular targets than chemotherapeutic agents. Targeted therapeutic agents or targeted therapies, they provide for use of personalized therapy. And we did mention this earlier about the personalized therapy. So the targeted therapy provide for use of the personalized therapy based on the biology of the individual's tumor. Because we have to study the patient's individual tumor and analyze it and have report and have, specific, information about it from the pathology and histology. And based on, based on the results, then we can develop the personalized therapy, and then the targeted therapy will be more effective. The targeted therapies, they work at sites that are on the cell surface or at the intracellular level inside the cell, or in the extracellular domain. So they can be like on the top of the cell, inside the cell, or even in the extracellular domain, which is interstitial or intravascular. Testing can be used to identify whether a specific targeted agent will be effective or not. We can test the effectiveness of specific targeted agents before being used. Cancer cells can become resistant to these targeted therapies. And the reasons behind that, or this can be attributed due to that the target changes through mutation, and the therapy no longer interact with it. So this can occur because the target changes through mutation, and the therapy is no longer interact with it, or because the tumor finds a new growth pathway and no longer depends on the target. So either due to mutations or due to the modifications that the tumor had found, so that they are growing, or the growth pathway has changed, so no longer depend on the target. That's why the cancer cells can become resistant to these targeted therapies. So because of the possibility of that resistance, then the targeted therapies work best in combination or in combination with the chemotherapeutic drug. So it works better if it's combined with another chemotherapeutic drug. Immunotherapy and targeted therapy, in terms of side effects, the administration of one type of immunotherapy usually induces the endogenous release of other agents. So as we administer this immunotherapy, then we are inducing the release of endogenous, endogenous release of other organs. So the release and action of these agents will result in immune and inflammatory responses. And in this case, it's systemic. It's not localized. So the administration of any type of this immunotherapy, it will induce the endogenous release of other organ of some agents from certain tissues. So the release and the action of these agents would result in systemic immune and inflammatory responses. So these responses, inflammation and the immune responses, are systemic. Then the toxicities and the side effects of these agents, they are related to the dose and the schedule of the immunotherapeutic agent or immunotherapy. So in other words, the extent of the side effects, the toxicities, that is related to the dose and the schedule of the immunotherapy. The acetaminophen and large amounts of fluids will help decrease the severity of the flu-like syndrome. Other side effects would include the tachycardia, orthostatic hypotension, which is very common, and in addition to a wide range of neurologic deficits, also it has been observed with interferon and interleukin-2 therapy. The nature and the extent of these problems still not yet completely understood in terms of the exact mechanism about the nature and the extent, and the resultant side effect. But these symptoms are, or these problems, still they are very frightening to the patient, because they must be taught to observe for neurologic problems. Like, for example, when you warn them or when you educate them to monitor the patient for confusion, for memory loss, for difficulty in making decisions, and insomnia. Initiation of safety precautions. So these problems are frightening to the patient and the family, who must be taught to observe for these neurologic problems. So in nursing management, we will assess and evaluate the patient's side effect and tolerance to these side effects. And we have to be proactive, and appropriate nursing care should be proactively initiated. And the care plan is supposed to prevent these problems, because that's the anticipation from the nursing team, is to prevent, and if it happens, then to intervene. But mostly here, it's more prevention, an anticipation, or being proactive in terms of the implementation of appropriate nursing care in a proactive way. Hormone therapy, sex hormones, steroids, the hormones and substances that are produced in endocrine glands and function as chemical messengers in the body. These hormones, like hormones estrogen and progesterone, they can enhance the growth of some breast cancers. Androgens like testosterone, they can enhance the growth of some prostate cancers. When these hormones are given as a cancer treatment, drugs like hormone therapy, these drugs or hormone therapy, they can block the efforts of the hormone and stop the growth of the cancer cells. Steroids, for the steroids, they are used in combination with other or with many drugs to treat cancer. So the anti-inflammatory agents, they reduce the swelling, the inflammation, which may contribute to cancer pain. So cancer-related pain can be treated with the anti-inflammatory drug because the anti-inflammatory agent can reduce the swelling and the inflammation, which contributes to the cancer pain. And they are also used with other drugs like the ondansetron, which is the antiemetic, to control and prevent nausea and vomiting, which also will be caused by the chemotherapy. In addition to the drug manipulation of the hormones, surgical interventions like oophorectomy, which is the surgical removal of the ovaries, can be used to remove the effect of the hormone on cancer growth. Colony stimulating factors, which is the hematopoietic growth factors. Hematopoietic growth factors, these factors are used to support cancer patients through the treatment of the disease. So the erythropoiesis stimulating agents, which is the ESA, erythropoiesis stimulating agents, the agents that stimulate erythropoiesis, which is the agents that would stimulate the bone marrow to produce blood-forming cells like RBCs and white blood cells and red blood cells, platelet cells produced from the bone marrow. So these agents, these erythropoiesis, stimulating agents to stimulate the bone marrow to produce these cells. So we can use these ESA agents. It should be used only when treating anemia specifically caused by chemotherapy. So when the patient developed the severe anemia from chemotherapy, we can prescribe them erythropoietin, Procret, which is a hormone that would stimulate the bone marrow to produce RBCs. Because anemia has resulted as a side effect from the chemotherapy. So that these agents should be used only when treating anemia specifically caused by chemotherapy using the most recent administration guidelines. So we have to be careful when we prescribe these medications, Procret, epoetin. We have to monitor the patient's CBC and lab weekly basis in order to determine the dosage for these agents or these hormones, like Procret or erythropoietin. So these ESA agents, the use of these agents is avoided in patients receiving chemotherapy with the intent to cure the disease. So while taking the chemo, it's recommended that we give them these agents. However, the use of these agents has raised safety concerns because they can cause potential harms like thromboembolic events, which is like a DVT, a pulmonary embolism, and thromboses, and increase the risk for death and for serious cardiovascular events when administered to a target hemoglobin greater than 12. So that's why it's it's a serious intervention when it comes to EPOE and the erythropoiesis stimulating agents. Once the patient's hemoglobin is 12 or above, it should be held. We should be administered that to a patient's hemoglobin greater than 12 grams per dl. Otherwise, the patient will experience either it can result in death or serious cardiovascular event when we administer the patients whose hemoglobin level is 12 or above. So therefore, the lowest dose should be used of this hormone, which is like procret or epoetin. So the lowest dose should be used that will gradually increase the hemoglobin to the lowest level, sufficient to avoid the need for blood transfusions. So in other words, that we will administer these medications just to slightly elevate the hemoglobin, so the patient's hemoglobin won't drop less than like 8 or 9. If it's 10, that's even better, or 11. So, but above 12 or above, it should be held, should not be administered. But to be on the safe side, and so for safe, to administer it within e-safety or within e-safe guidelines, within like recommended guidelines, we sometimes administer at the lowest dose to sufficiently avoid the need for blood transfusions. So in other words, that we want to maintain blood, not to drop less than 8 grams per dl. Answer to this question would be B. Encourage the patient to implement a daily walking program. And given that the exercise and activity within the tolerable limits are often helpful in managing fatigue, walking programs are a way for most patients to stay active without being overtaxed. The peripheral stem cell transplantation, which is an effective life-saving procedure for a number of malignant and non-malignant diseases. The bone marrow transplant and the peripheral stem cell transplant, they allow for the safe use of very high doses of chemotherapy agents and for radiation therapy in patients whose tumors have developed resistance. So for those whose tumors have developed resistance, then those two modalities would be the best. Or in those patients whose tumors have failed to respond to the standard doses of chemo or radiation. In other words, that it's very effective in patients whose tumors had developed either refraction, which is resistance, or failed to respond to the standard doses of chemo or radiation. Although that these two modalities or procedures are life-saving, the patients may have long-term or delayed complications that can affect quality of life. The hematopoietic stem cell transplantation, this therapeutic approach, which is SCT, we use in the past, historically used to be referred to as the bone marrow transplantation, because the bone marrow was the original source of the stem cells when the procedure was first developed. So this, even hematopoietic stem cell transplantation, typically was typically referred to be known or called as a BMT, which is the bone marrow transplantation, because scientifically known that the bone marrow was the original source of the stem cells when the procedure was first developed. However, the advances in the harvesting and the cryopreservation techniques to preserve these cells have opened a new pathway to the collection of the stem cells from the peripheral blood. So consequently, now the terminology has changed now, and no longer the stem cell transplant, the hematopoietic stem cell transplantation is referred to be as BMT. Now, consequently, the term or terminology has changed, and it's referred to be called hematopoietic stem cell transplantation. So even when the when the cure is not achieved, the transplantation can result in a period of remission. And because it's a highly toxic therapy, the patient must weigh the significant risk, because in this scenario, we have to run the benefit risk ratio. And in this case, the patient must weigh the significant risk of treatment-related death, or treatment failure, which is a relapse. And that would be against which is the benefit in this case, and risk would be against the hope of cure. The benefit is the hope of cure, and the risk would be the treatment-related death or treatment failure, which is the relapse. So that's kind of scenario when it comes to analyzing the risk-benefit ratio. Patient must weigh the significant risks of treatment-related death or treatment failure, which is relapse, against the hope of cure. This slide talks intensively about the stem cell and the hematopoietic stem cell transplantation and the procedure. And then talks here about the gene therapy. Still, the gene therapy, which is still in experimental phase. Complications of cancer, nutritional problems, like malnutrition, including protein and nutrient deficiencies, electrolyte depletion, dehydration, weight loss, impaired wound healing. And in the book, you'll find some of the nursing interventions for each of these complications. And most important one here is the cachexia, which is the wasting syndrome. And the wasting syndrome, and in both of these scenarios, patient will lose lots of weight. So it can be used as synonyms as the same cancer, cachexia, or Westing syndrome, which is a complex and multifaceted syndrome characterized by anorexia and or unintended loss of weight and appetite. And patient in this scenario, in this case, would be severely emaciated, like skin and bone, and it is accompanied by the generalized tissue wasting, skeletal muscle atrophy, immune dysfunction, and metabolic abnormalities. And most of the time, the problem here is that the weight loss cannot be reversed nutritionally. So if you give like nutrition and try to administer like nutritional therapies or interventions, that's not going to reverse the weight loss. Cancer patients can suffer from cachexia, especially those with upper GI and pancreatic cancers. And as the cancer progresses, then the cachexia can affect many cancer patients, and it's associated with the increased morbidity. Infections in another complication, and we have specific guidelines and instructions for patients, like instruct patients with a risk of neutropenia to call their healthcare providers with any temperature above 100.4 Fahrenheit, because that's an indication of infection, and given that they have a neutropenia, and which means they are immunocompromised. So we're not going to focus on the oncologic emergencies because these are the complications in which we will cover all these complications in the adult Hill 3 in the fall. We cover all these complications called oncologic emergencies. So I think that concludes the lecture on cancer or concepts of patients with cancer.